You're listening to The Dead Prussian, a podcast about war and warfare.
G'day ladies and gentlemen, welcome to this episode of the Dead Prussian podcast. Today I am lucky enough to chat with Dr Meghan Fitzpatrick, a defence and security researcher whose research is focused largely on the psychological effects of war and warfare. Hi Meghan, how are you going?
Good, how are you?
I'm pretty good at the moment. It's midday here in Australia, so it's nice, bright and sunny. I know that I'm keeping you up late tonight, so I'll try and be pretty quick with my questions.
No problem.
Okay, so Meghan, can you just tell myself and the listeners a little bit about yourself and a little bit about what got you interested in your research topics?
Sure. I graduated with my PhD from the Department of War Studies at King's College London. And presently, as you said, I'm a freelance defense and security analyst. And in terms of how I got interested in this particular subject, well, I've always been fascinated by the subject of war and how it affects the lives of ordinary people. And I think I can kind of vividly remember sitting on the veranda at my grandfather's house as a little girl and listening to his stories about World War II. However, I only really became interested in the issues surrounding mental health specifically once I was at university. And in one of my undergraduate history classes, we were asked to write an essay about war, but I was looking for a new and sort of fresh approach to the subject. And in the course of my research, I came across something called lack of moral fiber, or LMF, which is an Air Force term that was used in World War II. And it referred to an airman who refused to continue flying, but had no physical reason for doing so. And it struck me as an incredibly odd term, and it immediately caught my attention. But more importantly, I think that it inspired me to dig deeper and to learn everything that I could, which, of course, eventually led me to shell shock and World War I.
It's interesting you use the term shell shock. So the way I understand shell shock is it's a condition that is usually only suffered by people that have experienced heavy artillery barrages. That's correct?
It's kind of correct. It's close to being correct in the sense that shell shock, the term originally was meant to refer to somebody who had directly, again, experienced a barrage or a bomb blast. And they believed that the symptoms that they were seeing in the field in 1914 were the result of that these bomb blasts were literally causing lesions in the brain to form, and that was what was causing the symptoms. But over time, they began to realize that this was actually incredibly misleading. And by 1916, they began to hypothesize that, in fact, shell shock, or what you would consider to be shell shock, that the majority of victims and patients, that they were actually developing symptoms and they'd been nowhere near a bomb blast. And in fact, only around 4 to 10% of patients that they saw had directly been close to a bomb blast. So the term was very misleading, and they drop it in favor of older diagnostic terms like neurasthenia and hysteria, disordered action of the heart. But by that time, it really had taken hold of the public imagination. And it actually continues, as I've used it, you've used it, it continues to be part of our modern lexicon of trauma.
So disordered action of the heart actually sounds something like a teen angst band would sing about.
Right.
Our topic today is actually war-related nervous disorders in World War I. So leading on from shell shock, how were war-related nervous disorders seen at the time of the First World War in particular?
Sure. Well, I think that in order to properly answer that question, you first have to understand how people saw mental illness in 1914. And at the beginning of the 20th century, there was a strong stigma surrounding mental illness. And at that time, patients were generally sent off to large asylums for residential care. And it's important to remember that the medical profession was still largely in the dark about the origins of mental illness and how best to treat it. And this is way before the introduction of effective psychopharmaceuticals. So there are no antipsychotics, there are no antidepressants, there are none of the drugs that we use so commonly now. So there was very little that a doctor could do for a patient who was mentally distressed. And I think that misunderstanding breeds stigma. Moreover, the elites of Edwardian society really firmly believed in a value system that celebrated things like virility, masculinity, resilience, stoicism, and willpower. In other words, that stereotypical idea of the British stiff upper lip.
Well, surely just a dash of stoicism can fix anything, can't
it? Not everything. And mental illness seems to challenge all of those values all at the same time. And at the turn of the century, there were also many notable doctors, there's politicians and intellectuals who sincerely believed that the British people were in decline as a race. And they concluded that urbanization, industrialization was producing physically and mentally weaker individuals. And this was popularly referred to as degeneration. So given that background, I think you can readily understand why people in 1914 were incredibly disturbed when previously very healthy, robust young men begin to present with a variety of very mysterious symptoms, including anything and everything from anxiety and palpitations to tremors, and on the extreme side of things, functional blindness, deafness, to partial paralysis. And in December 1914, the British Expeditionary Force is reporting that nearly 7 to 10% of its officers and 3 to 4% of the other ranks are suffering from what they're calling nervous illnesses. So in the midst of a war for survival like this one, this really represents a crisis. And for the British Army, it was completely overwhelming.
It's interesting what you say about the urbanisation, industrialisation, how they saw that bringing a decline in the British race. Having grown up in remote rural Tasmania, I too believe that living in the city makes you softer. However, it probably doesn't relate or correlate directly with how a war-related nervous disorder comes about or is diagnosed. Can you describe how they went about diagnosing these related nervous disorders, given that the view at the time didn't really seem to be understanding of how these disorders were caused? Therefore, I'm sure that there wasn't a simple diagnostic that you can take to apply to your patient. I'm sure they didn't have medical officers walking around with checklists to see whether or not someone had post-traumatic stress disorder.
No.
What was the process they used?
Sure. Well, typically a soldier would initially be sent to see a regimental medical officer near the front lines. And at that point, they usually allowed the patient to rest for a day or two. They would probably give him a sedative. They would probably give him a cup of tea. Unsurprisingly, there seems to have been a very strong belief in the healing powers of tea.
A good cup of tea can fix anything, can't it?
Exactly. And afterwards, the medical officer would conduct a series of tests, diagnostic tests, and a thorough physical exam. And they would assess whether the symptoms like a tic or tremors could be traced back to an identifiable physical injury. And if they couldn't, the patient might be then sent to a specialist neuropsychiatric center for further observation and treatment. Or they might even be sent back for diagnosis and treatment back in the UK. But it's crucial to point out really that individual experiences of that process varied widely because of the confusion surrounding diagnostic terminology. So, for example, like we've been discussing, shell shock, a term that we're all very familiar with today, starts out as something that's supposed to refer directly to the results of a concussion or a bomb blast. And then as time goes on, they discover that that's not actually accurate and begin to use other terms, which are probably equally confusing when you start to think about it.
Yeah.
And then consequently, they abandon these terms, but again, remain incredibly confusing to be able to define accurately.
I'm sure lack of moral fibre isn't a very definitive term to use, although that was later used in World War II, you said, was that right?
Yeah, it was used during World War II by the Royal Air Force, and it was just essentially supposed to refer to airmen who did not have a physical medical reason for not flying. And it carried with it a very heavy stigma, and somebody who was labeled as having lack of moral fibre would really find their career in the Air Force at an end.
Yeah, I think recent history with also the Vietnam War and the way that veterans around the world, particularly in the Western world, has been identified that a stigma around mental illness is certainly not one of the steps towards finding a cure. Which leads me into the next point. And there are some mental illnesses out there that something that the sufferers will have to live on with for the rest of their lives, because there's not always a cure or a fix-all for some of these conditions. In general, what were the effective and also, I guess, the ineffective responses that they used towards war-related nervous disorders in World War One?
Well, I think I'll be a typical academic and say it really boils down to how you define effective. In the field, medical officers and psychiatrists were really focused on returning men to duty as soon as possible.
Okay.
And military psychiatry was, and I think that it remains, an incredibly pragmatic discipline. And I can remember a quote from a Canadian medic, Dr. John Bezic, and he served during the Korean War. But I think that it applies equally well to World War I, because it really sums up the practical tenor of military psychiatry. And I believe he said something like, people get squirrely in war. There's nothing wrong with the guy who draws ducks on the wall. However, when he starts to feed them, you have trouble. Yeah, granted, it's a very silly quote, but nonetheless, it does reflect something more serious. In the midst of war, manpower considerations are paramount. And that means that doctors are principally interested in relieving those symptoms that directly interfere with combat effectiveness.
Yeah.
And the soldier's ability to function is prioritized over restoring his previous state of mental health.
Okay.
And during World War I, this eventually led to the development of a treatment system that's referred to as forward psychiatry. And it's actually still in use all over the world today. And the tenets of forward psychiatry are best summed up by this acronym called PI. And it stands for proximity, immediacy, and expectancy.
Okay.
So in other words, you treat the patient as close to the front lines as you can, as quickly as you can, and with the expectation that they will return to duty. So throughout the war, they gather evidence, and that suggests that patients worsened the longer that it took them to receive treatment, or if they were removed from the front lines preemptively. Furthermore, you need to treat the patient not like a victim, but with the expectation that recovery is inevitable, that they are a soldier first, not a victim. Now, having said that, there were, of course, patients who would have to return back to the UK. And then, once again, the treatment methods vary incredibly. As a patient, the care that you received really depended on the individual medical officers and the doctors that you encountered along the way. And it's debatable as to which of the methods was most or least effective. There were experiments in everything, so from talk therapy to hypnosis to the use of physical treatment methods like electroshock. And treatments available also varied depending on whether or not you were an officer.
Okay.
So for the most part, officers are sent to private homes and institutions where they probably would have encountered a specialist like a neurologist or a psychiatrist. So, for example, someone like the poet Siegfried Sassoon, who was sent to Craig Lockhart Hospital in Edinburgh, and he encountered Dr. William Rivers, who is a very distinguished academic and clinician. He was also a very cultured man who used talk therapy as a means to engage with and to help his patients. However, Sassoon's story really isn't very representative because, first of all, Sassoon publicly opposed the war. And he was sent to Craig Lockhart instead of facing a court-martial. It was one or the other. But more importantly, Sassoon and his fellow officers received, I think, a level of attention that was out of reach for the majority of their subordinates. The vast majority of the other ranks were actually sent to general hospitals, where they were very unlikely to ever see a specialist. And the treatment they received is minimal at best. It usually involved an exceptionally bland hospital diet, so lots of potatoes and bread and milk, and lots of bed rest as a means to recuperate from fatigue, but that's pretty much it.
Okay. It's an interesting mix of history that you've presented us with. The idea of the forward psychiatry in a global total war where a lot of commanders out there were probably thinking, I don't really have time to be dealing with casualties on the front line. The fact that they implemented those changes and were forward-looking in enacting that sort of system, it's kind of comforting, I suppose. But then what you wouldn't expect is that the treatment worsens the closer the individual is to home, and that kind of sounds like what it was.
Right. Well, the theory behind that is the idea that the person who's experiencing mental health problems will start to adopt an attitude of defeatism the further and further they get from the front lines. So if they expect that they'll be returning to duty, if they expect that they are able to recover, then they will. But if the doctor treats them as if they're ill, as if they are a patient, then their symptoms will worsen over time.
Okay. And is there much, I suppose it would mostly be anecdotal evidence on the camaraderie between soldiers is something that he's often written about. Even old Willie Shakespeare wrote about it when he was talking about Henry having some fun in France.
Right.
How did other soldiers react to these casualties? I mean, if it's 10% of officers roughly and 4% of enlisted men, then there's a lot of soldiers out there that are relying on their friends, and they wouldn't have the education packages that the modern soldier has on mental illness.
I think it's a variety of reactions. Of course, I think they had sympathy for the people who were around them and were certainly aware of how difficult it was to be able to live and fight on a front line. But equally, I think that sympathy only went so far. Mm-hmm. Because if they lost more men, it meant more difficulty for those individuals if they were left on the front line. So I think their sympathy was limited to, allowing them to maybe have a break from the front lines, but not necessarily to allow them to continually seek treatment for mental health issues. And you can see that in the sort of annoyance, the letters that they write home about each other. Mm-hmm. And some of the terms that are used for people who experience mental health problems would not be very appealing to the modern mind. Things like scrimshanker and swinging the lead or malingerer, those sorts of terms are used quite frequently. And I think their sympathy really only extended so far. I mean, if it interfered with their lives and their ability to survive on the front line, it ended there.
My next question's I've just realised is going to be quite a difficult one to answer. So I'm going to give you a bit of leeway and ask for the Cliff Notes version. Cliff Notes is pretty much how I got through my undergrad degree. It's been 100 years since the First Great War, the First World War, or the Great War as it was known. We've had quite a few conflicts, particularly in the 20th century since then. We had another global total war not too long after it. It seems like there was a lot of lessons learnt, actually, about war-related nervous disorders. How were these lessons that were learnt, how were they applied during later conflicts and later generations? A reminder, just the Cliff Notes, because I know I've pretty much just asked you to summarise nearly 100 years' worth of military psychiatry there.
Right, wow. So, well, in terms of the very complicated lessons, I'll try to give the Cliff Notes, as you say. Shortly after the armistice, there's a War Office Committee of Inquiry into Shell Shock, which was better known as the Southborough Commission. And it was convened to actually consider those lessons that you're mentioning. And the commission eventually releases its findings in a report that's published in 1922. But despite their best efforts, their conclusions are actually very ambiguous. And following demobilization, the British military itself really loses touch with developments in the wider psychiatric profession. And the vast majority of psychiatrists who join the armed forces during the war leave in favor of more comfortable civilian appointments. And to put it very bluntly, peace didn't offer the same sort of opportunities for clinical experimentation and advancement as the war had. So by the time that World War II rolls around in 1939, there's been a significant loss of institutional memory.
Okay.
However, the authorities in the War Office, they realized that they can't ignore the problem altogether. After all, there were still around 35,000 British veterans who were drawing pensions for psychiatric disabilities that were related to war service as late as 1937. So that's a huge financial burden, and they can't afford to repeat the same mistakes. So the British, the Canadians, the Australians, the Americans, all of them invest very heavily in selection and screening programs. And these are designed to keep men prone to breakdown out of the armed forces. But as they eventually discover, it's almost impossible to accurately predict how the average person is going to react to combat until they actually find themselves in that situation. And it takes them a few years before they invest in and organize psychiatry to the degree of complexity that they did during World War I. So, for example, they only rediscover the principles of forward psychiatry in 1941 with the Siege of Tobruk and the Western Desert Campaign. And unfortunately, you could argue that the pattern continues and repeats throughout the Cold War. So, for example, in 1945, demobilization happens, and once again, psychiatric programs are downsized or they're dismantled altogether. And the psychiatrists themselves leave the armed forces. And it certainly didn't help that they weren't very well liked by their military colleagues at the time, who often believed that they were very soft-hearted and didn't understand the brutal demands of military life.
Well, didn't General Patton get himself in trouble with reaction to psychological casualties that he visited once?
He got into a lot of trouble for what he did, ended up slapping a soldier, and I believe he was dismissed from his command because of that action.
Yeah.
Yeah, not great, no. And generally, military psychiatrists, as I said, they weren't very well liked. And one of their nicknames was trick cyclists. It was one of the kind of derogatory terms used for them. So when the Korean War begins in the summer of 1950, the UK and the other Commonwealth countries, like Canada and Australia, are really unprepared. And the early medical support for that war was very fragmentary. Only 5 years has passed since World War II. But again, it takes time for those in command to realize the value of frontline psychiatric treatment. Now, thankfully, I think that we finally started to break that pattern over the past 20 or 30 years. And there's been increased investment in military mental health programs globally. So, for example, British soldiers always deploy with specially trained mental health nurses. And there are programs that are designed to help troops cope with deployment. There's definitely still room for a lot of improvement, but I think that at least we're going in the right direction now.
Yeah, I'm sure the just the access to information these days is making a lot more of that institutional retention of knowledge possible.
Definitely.
So
it normalizes things.
The way that you've approached the studying this topic as an academic must have been quite a fascinating historical study. But to the modern military and medical institutions, what is the key lesson that can be learned? I think, based on your answer to the previous question about what happened in the 100 years between then and now, it must relate something to institutional lessons, or
Right.
Is there a quick fix for modern military or medical institutions, or is this just something that they're going to have to keep learning the hard way?
Well, perhaps not a quick fix, but I think that, as we've been discussing, if we're not careful to identify those faulty patterns of behavior, you're going to repeat the same mistakes over and over again, and that can be to devastating effect, especially for something like mental health. But on a different note, though, the basic sort of tenets of military psychiatry as developed during World War I essentially remain the same today. And I think you'd be surprised just how similar. Because since 1914, war itself has changed radically with the introduction of new technology, and you could say the same about psychiatry, revolutionized by new drugs, treatment options, and military psychiatrists have certainly felt the impact of those changes. However, they continue to use those same basic principles of proximity, immediacy, and expectancy, and it's because they remain valuable. And I think that medical officers can still learn a great deal by reading about and studying their predecessors. They can only benefit from their hard-won experience.
I like nothing better than when someone says the answer is in history. Pick up a book, because that's kind of what we're about here at the Dead Prussian. I do know that amongst law enforcement officials and also some military members, the books by Dr. David Grossman, or Lieutenant Colonel David Grossman, are retired, on killing, on combat. They're kind of, I like to call them the John Grisham versions of clinical psychology and psychiatry for the layman.
Right.
Are there any other sort of books you'd recommend? Have you written a book?
I do have a book actually coming out this year, and it's called Invisible Scars, and it's reflections on mental trauma in the Korean War and beyond. And that comes out with the University of British Columbia Press sometime this year. We'll have to figure out an exact date. That's still to come. Yep. But in terms of reading that you can do to get a more general overview, One of the best books that I think is available is A War of Nerves. That's by Ben Shepherd. And another good one is Shell Shock to PTSD, and that's by Edgar Jones and Simon Wesley. And it's a bit more clinical, but it certainly provides you with a great overview of the subject and is probably good for somebody who's looking for technical lessons to draw from war.
That's actually a very good recommended reading list. I have read none of those books, but I will now go and read some of them. In fact, they're probably books I should have read before asking one of the leading academics to come on the show. Lessons learned for myself. On this show, The Dead Prussian, we always ask one final question of all people that come on here. And this relates to our continual search not to just define war in a very specific sense, but to understand what war is culturally, politically, technically, and societally, personally. So I will give you the lead into the sentence, and I'll ask you to finish the sentence. My lead in is, war is...
For somebody who's studied war for the past decade, it's actually remarkable how challenging this question is when you really start to think about it. However, I did take some time to carefully consider this and generally came up with a socially sanctioned form of violence designed to achieve a set of goals as defined by the belligerents, including anything from territorial and political gain to the domination of resources, or perhaps to fulfill a religious or cultural narrative that has lasting and largely unforeseen implications for both the participants and the surrounding societies.
Wow, that's quite a complex definition. I think I noticed a few commas in there as well, so...
definitely a few commas.
Definitely not getting that into 140 characters in a tweet, which is something we tried a couple of weeks ago, and we realised that nearly everyone who interacts with the Dead Prussian podcast is too verbose, myself included.
Yeah, I think that's a bit of a difficulty to try to fit into 140 characters.
So, Megan, thank you very much for your time today. It's been great to learn about war-related nervous disorders, because it is something that relates not just to the past, but to the present, and will relate to the future. It's interesting to see where our forebears have been with clinical psychiatry in the field, and it's also interesting to see that the lessons that were learnt 100 years ago remain relevant and applied to treatments that are applied today. So thank you very much for your time.
Well, definitely. It's been my pleasure. Thank you for inviting me.
And we'll keep an eye out for Invisible Scars, Reflections on Mental Trauma in the Korean War and Beyond. And we might try and invite you back to talk about the Korean War, given that we did ask you to cover 100 years of history in a very, very short time frame. So we'll make sure we give you a chance to expand on that a bit later on.
Absolutely. It would be my pleasure.
Okay. Thanks, Megan.
Thank you.
Join the conversation with us on Twitter at Dead Prussian Pod, on Facebook at The Dead Prussian page, or on our website www.thedeadprussian.com. All show notes for this episode, as well as copyright information, can be found on the website. The Dead Prussian podcast is written, produced and hosted by Mick Cook. It is co-produced by Amanda Levito. The music used throughout is Caught in the Beat by Broke for Free and is used under a Creative Commons Attribution license. All opinions expressed by individuals on the podcast are those of the individual and not necessarily representative of any other organisation.